Okay, welcome everybody. Yeah, as Andrew indicated, this is a Heart Failure Awareness Week. Actually, the week started in the past weekend where there is a heart failure update in Hotel X, and there's a lot of attendance. So it's a happy gathering. And I would kick off this Heart Failure Awareness Week by telling you about the Heart Failure Clinic, both in clinical and in research. So for this week, we have today's the kickoff. We also, you can visit the National Heart Failure Awareness Week website for more information. Tomorrow, we will have educational seminar for patient and family members. I heard that there will be about 70 attendees. So on Wednesday, there will be a webinar presented by the Heart and Stroke Foundation and Heart Life Foundation from coast to coast, navigating symptom challenges and united strategy in the heart failure clinic. There will be a drop-in in room 7611, Squires Conference Room, or you can register here. In the 7 Carter South and 7 Carter North, there will be informal discussion with the nurses on heart failure. On Thursday, there will be CCU round for residents with case presentation, and we will wrap up on Friday. So what's the objective today? As before, I want to review with you the heart failure clinic, and now we have amyloidosis clinic. To tell you that what I've been doing, we've been doing something in contrast to what you think, and this will be focused on patient care as well as clinical research. So this is the heart failure program patient care, and we have the director and physician, that would be Abdul Al-Hussein, and myself. We have the administrative staff, who's very, very diligent, and this is Francis Lee. And of course, we have the nurse practitioner who see patients, share with me, and also doing inpatient assessment, Haitham Shara. So these are the number of patients under active treatment. So we have about 1,000 patients in the clinic, but we have 500 that is actively pursuing guideline-directed medical therapy, which I will review with you later. And in the amyloidosis clinic, we have access to ATTR-specific therapy, and there's about 50 patients undergoing this kind of therapy. Again, I would mention them to you later. So these are some of the updated statistics. First of all, the office visit, heart failure clinic office visit from 2022 to 2024. You can see there is a progressive increase in the number of heart failure visit, in-person visit. And the orange is phone visit, the peak at 2022, but subsided when the COVID pandemic concluded. And so was the video conferencing like the Zoom. But I think the nice thing to see is that there is a progressive increase in inpatient visit. Now, I have to say that this is limited in part by resource in terms of physical space. So even if I want to see more patients tomorrow, I probably cannot just because I don't have the space in the hospital. And this is hospital discharges. And I have to emphasize this is all discharge from heart failure, so they're not necessarily patient follow in the heart failure clinic. And this is hospital discharge. So if the patient admitted for a non-heart failure diagnosis, but somehow developed heart failure during the admission, they will be counted too. So this is just discharge heart failure diagnosis. So you can see that the hospital discharge from heart failure has reduced gradually from 2022 to 2024. And I have to tell you that the December 2024 data is still not yet available. So this would be everything except for December 24. So there are a couple of game-changing clinical trials that leads to the heart failure clinic. The first one is the DEPA of the DELIVER trial. is to look at the dapagliflozin in heart failure with mildly reduced or preserved ejection fraction. And these are patients with ejection fraction of 40 or above. So in this case, there were 6,000 patients, and it was the largest and broadest heart failure trial in patients with heart failure with moderately reduced ejection fraction and heart failure with preserved ejection fraction. 6,000 patients, LVEF more than 40% with evidence of structural heart disease, such as LVH or poor motion abnormality. They have the elevated NT-proBNP. They can be ambulatory or hospitalized, and they have the EGF of more than 25. And these patients are randomized 1-to-1 to dapagliflozin and SGLT2 inhibitor or placebo. It's a fixed dose, so there's no titration required. The median follow-up is 2.3 years. The primary endpoint, as in most heart failure trials, is a composite of cardiovascular death or worsening heart failure, which is defined as hospitalized heart failure or urgent heart failure clinic visit. The full patient population and the ejection fraction less than 40%. Secondary endpoint are total number of hospitalized heart failure, first and recurrent heart failure, and cardiovascular death, change in KCCQ total symptom score in 32 weeks, cardiovascular death, and all-cause mortality. The baseline characteristics, you can see that it's very applicable to ordinary heart failure practice. NT-proBNP 1011, average ejection fraction of 54%. Half the patients do not have diabetes, and half the patients have eGFR less than 60. 10% are hospitalized or reasonable discharge, and importantly, 18% patients have prior LVEF less than 40. And this will address the group we call heart failure with improved ejection fraction. So as a matter of fact, it's a trial that look at heart failure with moderate reduced ejection fraction, preserved ejection fraction, and heart failure with improved ejection fraction. So these are the primary endpoint. The primary endpoint, as indicated earlier, is a composite of cardiovascular death or worsening heart failure. Compared to with placebo, the dapagliflozin treated group had an 18% relative reduction of this combined risk. Absolute risk reduction, 3.1%, highly statistically significant. In terms of absolute risk reduction, number needed to treat to prevent one composite event is 32 subjects. You will agree with me that this is a very robust result. And the two curves started to diverge very early. So another drug that have gained, another trial, so to speak, that have game changing property for the heart failure clinic is ART-HF. We find ART-HF, we actually contributed 9 patients to this study, and it's a study of finerenone in heart failure with mildly reduced or preserved ejection fraction, similar to the DELIVER trial. So in this trial, patients who are on maximum guideline-directed macrotherapy, whichever the clinician wants, are randomized to placebo or finerenone with a top dose of 40 milligrams per day. Note that the top dose in the kidney trial is only 20 milligrams per day. So compared to placebo, there was a 16% reduction of this combined risk. Number of cardiovascular death and total heart failure event, P equal to 0.007. And the difference in treatment effect on composite cardiovascular outcome were observed earlier and remain consistent throughout the study. And they also look at total symptom score on the left side, which is a KCCQ total symptom score. Compared to placebo, finerenone has a higher symptom score. In this case, it's good, okay? And there was no change in NYHA class, and the renal composite outcome is not different, which is in contrast to the Fidelity program, where there is an improvement in kidney function. The reason behind this is because of the follow-up is a bit short. I think if followed long enough, there would be a difference in the kidney outcomes. So the second topic I want to cover is the game-changing studies of amyloidosis specific therapy. So this slide looks complicated, but I just want to tell you that there are different types of treatment for ATTR amyloidosis. We have the suppressor. So they are the gene silencer, such as patisiran, inotersen, vutrisiran, or eplontersen. So these agents are injections. We inject every 3 to 6 months subcutaneously. And we also have the stabilizer. You all have heard of tafamidis, which is a drug that stabilizes the fibrils, so they would not become more toxic. And acoramidis is licensed in the US, and the FDA approved that. It's not yet in Canada. It's unclear when this will be approved in Canada, but we were involved with in the trial for acoramidis, and because of that, we have 5 patients who is currently on an open label therapy. They all seem to be doing quite well. And of course, there's this remover. These are still experimental. So these are the gene silencer available to the heart failure clinic. Inotersen, eplontersen is a 2O antisense oligonucleotide. For patisiran and vutrisiran, it's an RNA interference agent. And they have all been approved for treatment in neuropathy by Health Canada. But for Amutra, which is vutrisiran, is FDA approved for treatment of cardiomyopathy and of course for neuropathy, and I will present some results later. So the trial that led to the approval of Helios of vutrisiran in cardiomyopathy is called Helios B. Helios B look at the effect of the drug in patients who have ATTR cardiomyopathy. It's 655 patients testing an RNA interference therapeutic agent. So this is the primary outcome. On the left is the time to first event, which is a competence of cardiovascular death and heart failure hospitalization. So in this group of patients, there are 655 patients in total. 40% of patients already on tafamidis at baseline. So this will be combined therapy on this 40% of patients. So on these patients compared to placebo, the vutrisiran group have a better survival. And on the right is monotherapy with vutrisiran, so they exclude patients who were previously on tafamidis, and you got a similar separation of the survival curve favoring vutrisiran. So this is what available to the amyloidosis clinic in May 2025, okay? If you have wild-type ATTR amyloidosis, you can have tafamidis or vutrisiran. Acoramidis is not available in Canada yet, although some of my patients is on, just because they are on the open label trial. So if you have the hereditary ATTR amyloidosis, which is also called variant ATTR amyloidosis, you have the same tafamidis, acoramidis, and vutrisiran, which I forgot to list here. If you have an AL amyloidosis, the light chain disease, I refer to hematologists, and so they can give them chemotherapy. If you have polyneuropathy, vutrisiran is what we use because they cover both cardiomyopathy and polyneuropathy, and they are approved in the US at the moment, but I think it will be approved in Canada soon. Okay, so all these drugs except for acoramidis are available in the amyloidosis clinic. So because of the trials I mentioned, I have something to say regarding the phenotype and LVEF. So you all know about the HFrEF, which is heart failure with reduced ejection fraction, at this LVEF less than 40%. And there is the median group, LVEF 41 to 50%, who are called heart failure with mid-range or medium or mildly reduced ejection fraction. LVEF more than 50% is patient with heart failure with preserved ejection fraction. And heart failure with improved ejection fraction are those who have baseline LVEF less than 40%. But on the second acquisition, there is a more than absolute 10% increase in ejection fraction to about 40% on the second measurement. But knowing the clinical trial that I presented to you earlier, it is therefore proposed that that we can now separate into two groups only, and heart failure reduced ejection fraction, of which you would get the so-called Fantastic Four therapy, or heart failure with no reduced ejection fraction. It's HF and HF. Not a good term, but it may change in future. But this is to simplify everything. So you only need to worry about ejection fraction less than or more than 40%. So this is what we use at guideline-directed therapy in our heart failure clinic in May 2025. For ejection fraction less than 40%, we use ARNI, which is angiotensin receptor neprilysin inhibitor, or entresto. We will also use beta blocker, which will be either carvedilol, bisoprolol, or metoprolol long-acting, not available in Canada. So if the heart rate more than 70 beats per minute in sinus rhythm, we will add ivabradine, which is an IF current inhibitor. And if they're still symptomatic, we can use a cyclic GMP enhancer called vivresicate. Okay, of course, they should be on steroidal mineral receptor antagonists such as eplerenone or spironolactone. And regardless of LVEF, all patients should be on SGLT2 inhibitor. So if you have ejection more than 40%, you can use non-steroidal mineral quarter receptor antagonists such as finerenone that I discussed about. The FDA and European Medicine Agency also approved the use of ARNI in those who have ejection fraction more than 40%. The FDA is quite nice. They have an indication of ARNI in patients who have heart failure with reduced ejection fraction, but they don't specify the level. They want clinician to think, okay? So of course, you all know about the GLP-1 receptor agonists, such as semaglutide, and the GLP-1 and GIP agonists, such as torcetamide. So these are something that will coming up very soon. So, but the key word is ejection fraction of 40%. So let's go to the second part of the talk. So this will be a briefer talk today because there aren't that much to talk about for the heart failure clinic. So we are very active in clinical research. And these are the staff, the personnel. We have the research investigator, such as myself, and the research manager, which is Carlos Fernando. He's also a research coordinator. And then we have the coordinator, and this includes the coordinator for the collaborators such as structural heart disease and nurse practitioner, basically, who recruit patients for the research. And under myself and the research manager, we have students, we have volunteers. So I want to go to some of the clinical trials that we are currently recruiting or about to recruit that I'm excited about. The first trial is Aurora HFpEF trial, sponsored by Bristol Myers Squibb. It's a phase 2A study to evaluate the safety, tolerability, and drug level of BMS 986435, also called MIG-224, in participate with heart failure with preserved ejection fraction. It will be conducted at our satellite clinic, Toronto Heart Center. So what's the mechanism and action of MIG-224? It's a cardiomyosin inhibitor, just like mefacamton that we're now using for obstructive cardiomyopathy. As you know, in obstructive cardiomyopathy and possibly in HFpEF, there is excess myosin-actin cross bridges. As a result, you have maladaptive sarcomere, abnormal remodeling, reduced compliance, and altered genetics. So the cardiomyosin inhibitor, such as mefacamton and MIG-224, inhibit the interaction. So if we normalize the myosin-actin cross bridges, The endpoint is improved relaxation, improved compliance, and improved energetics. So basically, MYC224 is a small molecule, selective and reversible inhibitor of cardiac myosin that brings cardiac myosin to the natural state and improve compliance, okay? And the difference between this and mefacamtin is the pharmacokinetics, and it is therefore believed that you don't need to measure the LVEF that often, because one of the potential side effects for cardiac myosin inhibitor is reduced ejection fraction. Actually, the Bristol Myers Squibb has certain criteria for drug withdrawal if that's the case. It reversibly binds to cardiac myosin to restore the normal population or myosin head in the off state, and thereby reducing the excess cross-bridging and normalizing ATP consumption. Repopulate the super relaxed state of myosin, therefore restoring cardiac reserve. For pharmacokinetics is well tolerated and concluded in ongoing study. The half-life is 5 days, short time to steady state, and primarily metabolized by CYP3A4 with low polymorphic dependency, low potential for drug-to-drug intervention. It improved LV compliance, improved LV energetic, improved measure of cardiac wall stress and injury, such as anti-proBNP and troponin. And that's been documented both by mefacamtin and MYC224. So the Aurora H half-PEV trial is cohort 4. So there are 4 cohorts. We were involved with the 3rd cohort. The 4th cohort is a dose response study that will come up with the optimal dose. So hopefully in future, in the outcome trial, they don't need any titration and just 1 dose. I don't know what the dose will be, but patient with symptomatic HFpEF, heart failure with ejection fraction more than 55%, NYHA class 2 to 3 with elevated BNP, LVH or increased filling pressure or left atrial enlargement, are randomized to the flat dose of 15 milligram, high dose of 25 milligram, high dose with LVEF-based titration, 25 to 35 milligram at week 8, and placebo. So 4 arms, and these are the protocol. The primary endpoint is safety and tolerability. Secondary endpoint is pharmacokinetics. The exploratory endpoint is NT-proBNP, echocardiographic parameters, and troponins. So another trial that will start imminently is the Hermes trial. And Hermes trial is the effect of siltavicimab, which is an anti-inflammatory agent, versus placebo on morbidity and mortality in patients with heart failure with mildly reduced or preserved ejection fraction, but accompanied by systemic inflammation. And there is another one trial called LEVEL trial, which is phase 3 double-blind randomized placebo study of levosimendan in pulmonary hypertension in patients with heart failure and preserved ejection fraction. But I would also only spend more time in Hermes. So Hermes studied siltavicimab. Siltavicimab was the first fully human monoclonal antibody directed against interleukin-6 ligand. This is an anti-inflammatory agent administered once monthly as a subcutaneous agent. Hopefully, by it blocking IL-6, you have less C-reactive protein. So this is the protocol. It's a phase 3A study. And it is inhibited 5,600 patients in the whole world with elevated hsCRP of more than 2 milligram per liter, NYHA class 2 to 4 symptoms, LVF more than 45%, elevated BNP with echographic signs of LV structural abnormality. Are randomized to placebo once monthly or siltavicimab 15 milligram plus standard care. Okay, and the design feature is double-blinded, 36-minute accruement, 4 years total duration, with interim analysis. The primary endpoint is the standard heart failure trial endpoint, time to first occurrence of cardiovascular death, heart failure hospitalization, or urgent visit for heart failure. The confirmatory secondary endpoint in hierarchy is number of hospitalization for heart failure and urgent care visit, time to occurrence of cardiovascular death, heart failure hospitalization, or urgent visit, time to cardiovascular death, and time to all-cause death. What is hierarchy? That means that you can, if you analyze the first endpoint, and if it is not significantly different, you stop analyzing. So that's a very powerful, robust kind of analysis. Another trial that we are waiting approval, but I'm very excited about because there's only a few trial look at HFrEF. It's called COMET-HF, which is a multi-center, double-blind, randomized, placebo-controlled trial to assess the efficacy of safety of omecamtiv mecarbil in patients with symptomatic heart failure with severely reduced ejection fraction. The study was sponsored by Psychokinetic, who manufactured the molecule, but in the Galactic trial, Amgen bought that, but now it's sold back to Cytokinetics. So omecamtiv is actually exactly opposite and mavacamten. Okay, so it is hypothesized that in heart failure, you have reduced interaction of the actin and myosin. So increase the entry of myosin into the tightly bound force position state with actin. So also like more hands pulling on the ropes. In the laboratory, it's found that the ejection time is increased, stroke volume is increased, but there is no increased myocyte calcium. That's important because why is the previous inotrope have increased mortality is because of increase in cyclic AMP and therefore increase in myocyte calcium. There is no change in DPDT. There was no increase in myocardial oxygen consumption. In the atomic AF trial, which is a phase 1 trial, phase 2 trial, and we were involved. It's a hemodynamic study, patient undergoing Swan-Ganz catheter. There was promising data, which came to the COSMIC HF trial with chronic therapy, and to the third phase outcome trial called Galactic, which we participate. We have lots of patients in that, but the drug was not approved by FDA because the positive effect was only seen in patients with severe heart failure and reduced LVEF. So this trial basically is an attempt to get FDA approval, but confining the recruitment to patients who have very low EF. So patients who have ejection fraction less than 30% within 6 months, NT-proBNP over 1,000 on loop diuretics, and heart failure event within 6 months are screened, and then the 2-week run-in period, and then 2-week washout period, and randomized to placebo or omecamtiv mecarbil plus standard care. So the primary endpoint is time to cardiovascular death, heart failure event, transplant, LVAD, or stroke. The recent stroke is involved in a galactic trial. There seemed to be a reduction in stroke. And to enhance the patient for adherence with run-in period, pragmatic design, because of a limited, safe, and ECG. The problem is that they would have to titrate the drug based on the LVEF and drug level. Another trial is in the site selection phase. It's the phase 2 multi-center randomized double-blind placebo-controlled safety and efficacy study of CDR-132L on reverse cardiac remodeling in participants with heart failure and preserved ejection fraction and left ventricular hypertrophy. And this study was is sponsored by Novo Nordisk. So CDR-123L is a synthetic nucleic acid DNA chimeric antisense oligonucleotide, ASO, and a selective inhibitor on microRNA 132-3b, MI130b. It is a central switch in cardiomyocyte, affecting the expression of gene that is involved in the transformation of cardiac tissue, including maladaptive hypertrophy and interstitial fibrosis. The main phase of the trial is designed to investigate the efficacy of CDR132L on suppression of plasma MR132 level. The find out the optimal dose of CDR132 for reducing plasma level of MIR132 in this patient population. And thirdly, to study the efficacy of CDR132L on inducing cardiac remodeling over a 24-hour period as evaluated by LV mass, LV volume, and NT-proBNP. So of course, we have a lot of collaborative study with third-party institution. With the UHN, we have the COVID VIHPR study, principal investigator Peter Liu, Canadian Cardiovascular Society, and many others, is to look at the COVID-19 vaccine-induced inflammatory heart disease, multiple funded in part by the CIHR. And there is another study at UHN by Dr. Anna Alba. It's called Discharge Stable Heart Failure Patient and Outcome. But my understanding is still in the RB submission stage. The talk will not be complete without mentioning the collaboration with Structural Heart team. We have a very strong clinical and research collaboration. The first trial is the Responder HF trial. It's a re-evaluation of the COVID atrial shunt device, which was previously documented to be possibly effective in a precision medicine trial to determine efficacy in mildly or preserved EF heart failure. And we have the gene PIT, which is phosphatase inhibition by intracoronary gene therapy in subject with non-ischemic NYHA class 3 heart failure, funded by AskBio, and principal investigator is Akshay Bagai and Michael Kutrick. And of course, we have the Empower trial, which is an international study to evaluate innovative, minimal invasive treatment for heart failure with early stage functional mitral regurgitation, sponsored by Cardiac Dimensions. But because I'm the vice president of the Chinese-Canadian Heart and Brain Association, also called CHABA, I sort of collaborate with them. And we look at the COVID-19 vaccination uptake and the myocarditis, pericarditis complication among the Chinese and South Asian individuals in Ontario. The study was conducted by myself in collaboration with my colleague, cardiology colleague, but most importantly, the staff of the ISIS. So I have submitted this to the CCC for abstract, and I finished the paper, and I'll just show you one result. And this is a table that looks at the crude rate of myocarditis, pericarditis on the 42 days after the first dose vaccination, overall and by exposure group, age group, sex, and vaccine type. So just look at by exposure group. The Chinese, compared to South Asian and general population, had the lowest risk for myocarditis, pericarditis, and the 42 days. Similar findings were observed in the second dose, and in terms of exposure to the vaccine, there is a bimodal distribution. Initially, the more general population patient have high exposure, but as the study goes on, this crossover to be Chinese are more prevalent than the general population. So that's all I want to discuss. As I say, it will be shorter than most talks. And I'm open to questions if you have any.